Good day, everyone. This is Laura Bonilla with JBS International. Thank you for joining us today. The Substance Abuse and Mental Health Services Administration Center for Substance Abuse Treatment's Division of State and Community Assistance is convening a webinar series for providers to give an overview of the Substance Abuse Prevention and Treatment Block Grant, or SABG. This series covers fiscal and programmatic requirements of the block grant. This session is being recorded for future use, so your participation is your consent to be recorded. Due to the high number of participants calling in, all participant lines will be muted for the duration of the session. If you have any comments or questions for presenters, please submit them to me by selecting Host or State TA in the drop-down menu in your chat window. To open your chat window, please click on the chat icon at the upper right side of your WebEx window. I will read your questions to the presenters during the question and answer period. Today's presenters are Larry Robertson, Project Director of SAMHSA State TA Project, and Rick Nance, Deputy Director of Business and Fiscal Operations for Illinois' Division of Alcoholism and Substance Abuse. CSAT Performance Partnership Grant State Project Officers, SPOs, will also be resources and provide clarification during the session and address follow-up questions following the session. If you have questions about block grant practices in your state, please contact your state agency. Rick and Larry, I'll hand it over to you.
All right, thanks, Laura. So let me do a quick sound check. I guess since you're not mute, I'll ask you if you can hear me okay. Or is he muted? All right, I'm muted. Rick, can you hear me okay?
Yeah, I can hear you. Yeah, I can hear you.
Okay, great. So good afternoon. I guess it's mostly afternoon everywhere else. So we're going to get started. All right, so I need to move the slide. Oh, page now? Okay. All right, great. So that's the first thing we have to do is get oriented to the keyboard. All right, so we're going to cover a little bit of, about the block grant. This is actually really more of an overview, but we want to give people a little bit of context. So again, this is Larry Robertson. I'm on the paper that Laura just read, I'm the project director of the contract that's doing this webinar. However, the reason why I'm doing this is because I've been working in and around the block grant for the last 25 years. And so we'll bring kind of the orientation from the work that we've done collectively here at JBS. And Rick is one of our lead consultants around block grant related matters, and so he'll bring that same framework. Also the framework of having worked in a state for a number of years. So just a little context, the first piece of which is that the Substance Abuse and Mental Health Services Administration actually administers 2 block grants. Anyone who's been around a long time, they know that these were formerly 1 block grant 25 years ago. So there's the Substance Abuse Prevention and Treatment Block Grant and the Community Mental Health Services Block Grant. We're going to talk almost exclusively about what we refer to as the SABG, the Substance Abuse Block Grant. It's about a $1.8 billion set of funds that SAMHSA administers to states, and it's pretty much one of the single largest sources of funding for substance use disorder prevention and treatment services throughout the country. So as I mentioned, we're going to talk pretty much about the Substance Abuse Prevention and Treatment Block Grant. Today's session in the webinar series that we're doing is actually focused on the perspective of provider organizations and intermediary organizations. And so what we mean by intermediaries are counties, managed care organizations, ASOs, any kind of organizations that actually are recipients of block grant funds. And a large part of the focus is really going to be on provider organizations that actually administer services. And so the block grant is much more complicated than what we're going to present, but what we wanted to be able to do today is provide an overview, a snapshot to give you some sense of what the requirements entail. And we'll talk a little bit about some of the other requirements right now that we're going to cover. So next week, Pam Baston is going to cover requirements regarding women and their children, special services for pregnant women and women with dependent children in particular. We'll be back in a couple of weeks after that to talk on December 7th to talk about access to care for priority populations. And then on the 14th, Rick is going to wrap up with an overview of the fiscal requirements pertaining to the block grant. And again, just understand the context that we're rolling with today and for the next few weeks will be primarily focused on what's important for providers to know. We do a more extensive training for states, and it's much more involved in this, but some of the requirements that are for states don't trickle down to the providers. All right, so today we're going to talk a little bit about the basis for funding, how does SAMHSA actually determine how to allocate funds, how the states allocate funds to providers. We're not going to spend a lot of time on that, but we'll talk a little bit about it. We'll talk about the requirements for engaging and providing access to those priority populations. We'll talk a little bit about the requirements regarding special services for pregnant women and women with dependent children. There are also a set of requirements that affect the block grant, one of which is affecting how the block grant interacts with faith-based organizations. And we'll do an introduction to some of the fiscal requirements and some of the other programmatic requirements that aren't otherwise covered before then. So a little bit about, just added a slide about authorizing legislation. So they actually are going to get the slides, or we've already provided?
Not yet.
Okay, so we'll be providing the slides, and so you'll have these same slides. If you're interested in finding a little bit more and a little bit about the implementing regulation as well here. The block grant is actually mandated by Congress, and it's actually funded to 60, this particular block grant, the Substance Abuse Prevention and Treatment Block Grant, funds 60 entities out in the United States. So it's each of the 50 states, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, the six Pacific jurisdictions, as well as the Red Lake Band of Chippewa Indians. And that's separated only because when we normally do this slide, we talk about both block grants. One of the differences between the two block grants is that the Red Lake gets money out of the substance abuse block grant, but not out of the mental health block grant, or not directly anyway. So the block grant has fairly specific purposes in mind. It's being awarded to grantees for the purpose of planning, implementing, and evaluating activities that prevent and treat substance use disorders, as well as promote public health. And you'll kind of see a large, significant public health component to it as we talk today and over the next few weeks about what the purpose and intent of the block grant is. So, all right, so I'm going to turn it over to Rick and talk about the block grant funding basis. Am I moving the slide?
Okay, thanks, Larry. Just like Larry, just to give you a little bit of background, I worked about 13 years in the community, and I've worked now about 28 years with the state, 25 of which I've been involved with the block grant. So that's kind of where, pulling all these things together and integrating it for providers, I think, is a key point. The way that the block grant is allocated is that states apply for the grants on an annual basis. It's non-competitive. It uses a formula based on economic and population factors, looking at how much funds are allocated to the various states across the country. They establish then their own base for how they allocate, each state does, for how they allocate funds to providers or intermediary organizations. So it's up to each state then to have those allocations, but the allocations have to be consistent with the SAMHSA requirements, and especially around priority populations and so on. Next slide. Okay, within the block grant requirements, there are specific requirements for the block grants in both substance abuse and mental health. Block grants have various what they call set-asides, otherwise a certain amount, within the block grant for substance abuse, a minimum of 20% of the award or the block grant that a state receives must be used for primary prevention. And then if you have HIV set aside, you know, then you are a designated state, you will have those. And I can go into the next slides will go into more detail. There's a children set aside then for the mental health block grant, and then there's the early psychosis and set aside for the mental health block grant. Next slide.
All right. Now I was just going to mention, Rick, that we just listed these other two block grants, but we're not going to cover the mental health block grants today.
Yeah. Yeah, the primary, as I mentioned, the 20% it's an annual amount from the federal grant fiscal year has to be spent on the prevention activities from the block grant funds received for that federal year. Next slide. And then primary prevention programs are those that are directed to individuals who've not been determined to need treatment, so they're actually prevention, and those should be programs that target education and counseling for individuals or provide activities to reduce their risk of further abuse. Okay, next slide. The HIV set-aside is for states who have 10 cases per 100,000 as designated by the CDC of HIV within their state. They are then, as a designated state, they're required then to spend 5% of their federal block grant award on HIV-related testing and counseling and outreach services, and so they must document that they've spent those services for those HIV-related services as a part of the block grant requirement. Next slide. The maintenance of effort is a block grant term where it looks at both, and we're going to talk only about the block grant for substance abuse right now, but it looks at statewide substance abuse disorder services, and they use special services for women and children, dependent children, and the mental health one will defer to the other sessions. But the MOE is a maintenance of effort requirement to have states maintain specific expenditures. Okay, next slide. The state expenditure MOE is determined by how much, or how I should say, the amount of expenditures that a state has for the prior two state fiscal years and then to the one that they're reporting for. So the one that you report for the current year, you have to maintain an average between the prior two state fiscal years in state funds to support substance abuse prevention and treatment, and this is in state funds. Next slide. The MOE for special services is that in the base year, 1993, states that had a block grant award had an established level during that year for which they were spending on services to pregnant women and women with children. They must be at that level or above that level for the reporting year. So they maintain that same amount of spending every year towards this targeted population. Next slide.
So Rick, one of the things I wanted to maybe put a pause on real quick is in terms of the relevance, just that we can talk to folks a little bit about the relevance of why we're mentioning to them these requirements that the state has to adhere to. And kind of it's a simple proposition that as the state receives these funds, it has to make decisions about programming. And so it will make decisions about certain types of services and how to allocate funds for prevention. So let's say a state gets $10 million in a block grant allocation. Automatically, 20% or $2 million of that $10 million have to be taken out for prevention. And so we want to be able to kind of convey to you guys how the block grant influences your state in fairly significant ways. And if I'm not mistaken, I think the block grant is the single largest set of funds for substance abuse prevention throughout the country.
Yeah, in many states, yeah, you're right, Larry. In many states it is. The other thing is that also at the provider level, this conveys to you why a state will mix funds, block grant with state funds, because they have to, you know, be able to meet that maintenance of effort requirement. So they will oftentimes, almost in all cases, have a combination of funds in an award at the provider level in order to meet this. The other thing is that this is also why they will have certain requirements for programs that at the direct level are serving pregnant women and women with children, because that's the set-aside is set up so that that amount of money has to go to programs that serve pregnant women and women with children. So the local provider has to be able to do those services and verify those expenditures, as well as the state.
Yeah. And one of the kind of the differences between set-asides and maintenance of effort is that typically the maintenance of effort was based on some formula that dates back to the early days of the block grant. So it was kind of fixed, and it basically says you have to kind of maintain that level over time, or in the case of the state maintenance of effort, it's really more recent. You have to maintain that level based on the 2 years preceding this year. So the state has some balancing act that it has to maintain, and a lot of these things, as Rick said, trickle down to the program level. The other thing I was going to mention too is that there are certain, over time, while the block grant has been around in its current form since the early 90s, it has been influenced over time by other regulations, including the Children's Health Services Act several years ago, and more recently the 21st Century Cures Act. And so we'll talk a little bit about how, actually one of the ways, Rick, I guess, is the fact that we used to talk about the tuberculosis and the HIV MOEs, which is
right.
the effort requirements, which were recently rescinded by the Cures Act. And so we don't have that as a part of our normal presentation any longer.
Well, and then even more recently, some of the evolution now in the maintenance of effort is state funds that go directly to the agency, but also where, providers need to collaborate with MCOs and those kinds of things, because those also at the state level go into the maintenance of effort cost.
So one of the points that Rick made earlier had to do with how things like the women's maintenance of effort requirement affect services. So for some programs, I'll just go ahead and cover this. The programs that are required to have this maintenance of effort requirement that dates back to like the early 90s for women's services, it's really about a certain type and level of service that has to be provided, and we'll cover those. For any states that use these funds have to make sure that they are using these funds for certain types of programs, and these programs we refer to them as for special services for pregnant women and women with dependent children. And when Pam does the presentation on this, she'll kind of go into great depth, but I just wanted to maybe list tick off the required services, and you'll see that it's a fairly comprehensive array of services for this population. And so the few include things like primary medical care, including prenatal care, primary pediatric care, including immunizations for the children's women, and obviously gender-specific substance use disorder treatment services and other therapeutic interventions for women. Therapeutic interventions for children in the custody of the women. That goes above and beyond the child care. That's also one of the items that is looking for. And because there's so many different services that have to be kind of knitted together, sufficient case management and transportation to reduce some of the known barriers to women and children accessing these services. And a lot of the requirements that came out of the block grant were pretty much based in some previous clinical research that demonstrated that the cost savings and the likelihood of positive outcomes are much greater when families are treated as a unit. And so in addition to the women, children being cared for in the services, but also having spouses and others who participate in some kind of way. And if any of you are big fans of the recently late Salvador Minuchin, you probably are believers in that as well.
Yes.
The big thing about this in terms of putting together these services is that they do not have to be funded all out of the states or the block grant funds. If you look at the range of services, and I'll back up real quick, particularly around things like medical care and pediatric care, a lot of these services for some of these women can easily be accessed through other means. The requirement is that these particular programs make sure that they either provide or they arrange for these services. And so if the programs that we have seen have been very creative and very resourceful over the years in putting together this array of services while minimizing the extent to which they use either block grant or state funds for this.
Yeah.
Do you have anything else on the funding for?
I was just going to say the key here is that they have access to those services.
Okay. So we have a question then? Okay. All right. So when I talked earlier about the fact that one of the purposes of the block grant has this very particular public health orientation to it, around the time, not too long after the block, or not too long before the block grant in its current form was promulgated, there were obviously concerns about HIV disease and tuberculosis and other infectious disease, as well as in utero exposure to alcohol and drugs. And so one of the things that Congress was concerned about was making sure that certain populations had access to care as quickly as they possibly could get it, or if they didn't have access to that care, that they did not fall between the cracks while they were awaiting services. And so we kind of colloquially have referred to these requirements as capacity management requirements. And what it really means is kind of the point that I was making, that they were intended to admit priority populations within prescribed time frames, again, to reduce the likelihood that folks would lose motivation, disappear, or fall between the cracks in between systems. And so one of the requirements of these capacity management requirements is to admit priority populations within prescribed time frames, which we'll mention. To also offer interim services to any priority populations who can't be admitted within those time frames. And to essentially have wait list systems that actually track, maintain contact with, and report on priority populations. And back in the day, wait list systems were largely paper, pencil, or you would send a floppy disk. And Laura was looking at me like, what's a floppy disk? They were these little things that you stuck inside of so that, you know. So just real quickly, priority populations, according to Congress, were two primary populations, which included pregnant women who were seeking treatment and individuals who were injecting drugs and also seeking treatment. And so those were the populations that the block grant really focused on. In addition, there are a lot of requirements in that really lay out what, how those two populations need to be addressed in terms of when they're waiting for services. One of the things that these programs have to do is give admissions preference in a very precise order. And so we listed on this slide what that order happens to be. So if it is a pregnant woman who also injects drugs, they should go pretty much to the front of the list in terms of a waiting list. Other pregnant women who are using other substances in other ways are the second kind of tier of clients to be identified. And then if there are individuals who inject drugs but are not pregnant, they're in the third tier in terms of preferences. We've seen states, go pretty much decide, or programs decide after that. The key is that if you receive block grant funds, you do need to understand that this is pretty much the required order in which things should occur. So we just wanted to make sure it was fairly clear to people. Whoever is number 4 is either determined by the state or determined by the program, but the first 3 are very precise. So that's a little bit about the priority populations. Then there's also the uniform waiting list. Back in the early 90s, or pretty much around the same time that the block grant was being developed and before it went into effect, CSAT published this uniform waiting list definition. Pretty much to this day, that definition in that document holds true in terms of what constitutes an adequate waiting list. The only difference is, again, today, most of the, a large part of the time, waiting lists are not paper and pencil. They may be electronic, or it could be some other kind of format. But nevertheless, it's a simple, as it says here, a simple law that identifies individuals who are actively seeking treatment. And obviously, it's when appropriate treatment slides are not available, meaning that the service capacity has been reached, and that those individuals meet eligibility criteria, clinical and otherwise. And one of the things that is important to remember with waiting lists is that, again, going back to that previous slide of the order, there should be some kind of way to ensure that people who are on that list are identified by their priority population designation. That, if we go back to the waiting list definition, there are some ways to determine the services that they receive, how long they've been on the waiting list, and some other factors to make sure that the conditions under which block grant requires people to be managed on waiting lists are being met, including the fact that they're receiving what we refer to as interim services. And so the waiting list definition and the block grant actually outlines the required elements of waiting list systems. It tells you when you need to report capacity information to the state. And essentially it basically says that once a block grant funded program reaches 90% of its capacity, it's sort of like a warning signal. You basically tell the state that we're almost full. So if it's a 20-bed residential program, for instance, once you hit the, you have 18 beds occupied, you want to send a notice to the state. If you have an automated capacity management system that you feed into, that notice is obviously going to be automatic because it will basically happen through the system. If you don't have that, you need to report to the state in some other means. And many of the states have their own means for determining how people should report to the state. Because of the concern about making sure that pregnant women can access care as quickly as possible, in particular, there has to be the ability for block grant funded programs to continually update capacity information about pregnant women, and to also refer those women to the state or to another provider if they can actually do so, so that the women stand a better chance of getting into a program that has the capacity to serve them. The block grant also outlines the conditions for removing someone from the waiting list. It's fairly basic under a couple of conditions. If the person refuses treatment, you can't make them go. If the person can't be found, you certainly can't serve them. And so those are the two basic conditions under which people can be removed from waiting lists.
Yeah, I might add to that, one of the things at the provider level that is important is for agencies to have policies and procedures about using the waiting list system for the state. So oftentimes they follow the state procedures, but they internally don't have policies and procedures that they need to have in place.
Yeah, and that's good. And if you're, like many things related to the block grant, if you have questions, as Laura said earlier, about how your state addresses particular block grant requirements, you certainly want to contact your state agency there.
Yes.
So the last component, so again, 3 components of capacity management really have to do with waiting, priority populations, waitlist systems, and interim services. And so the third piece is interim services. And so block grant funded programs must offer interim services within 48 hours if priority populations can't be admitted or referred to programs with sufficient capacity. That's generally the rule. The requirement is a little different for pregnant women than for folks who inject drugs, but generally speaking, if you can't do it within 48 hours, you have to start offering interim services. There are other conditions, particularly for folks who inject drugs, that you have to meet. You have up to 120 days to admit them into care, and there's certain things that you can do while they're in care. The requirements also outline what interim services might constitute, and so there's certain specific requirements, a lot of which look very much like addressing infectious disease types of concerns. So again, the whole notion of interim services is that it's kind of connected to the wait list issue, that you want to be able to maintain contact with folks who are on the waiting list on a continual basis, and interim services is certainly one of the ways that helps to do that. All right, so Rick's going to talk a little bit about, this is really about how do we actually ensure access to care, and Rick's going to talk a little bit about how do we engage these populations into care, and that's through outreach.
Yes, and I'm going to talk about outreach requirements. And agencies that receive substance abuse block grant funds for those individuals who are injecting drug users need to use an outreach model, much like identified within the regulations. There's a model that's described there, but they need to be evidence-based outreach models. And those models are really set up for the provider to contact and communicate with and follow up with those people who are at high risk of substance abusing behaviors, and as well as their family members, their associates, their neighbors. And so it's to provide outreach, and they are to do that to encourage people as they reach out to them, to encourage them to enter treatment, consider accessing early intervention services or some kind of services leading into treatment and recovery. So, next slide. I'm going to talk now about charitable choice, which is a piece of, go ahead, next slide, talks about the charitable choice legislation as well as the requirements as it pertains to the block grant. Charitable choice is applicable to block grant agencies, specifically to those that are faith-based programs. It allows them to be able to receive block grant funds under specific guidelines and conditions. The agency is able to retain and keep their religious character and the nature of their activities as such, and it helps them, to not be discriminated against because of the fact that they're faith-based. However, the block grant requirements do prohibit, the use of those funds for any kind of religious activities, and also you cannot discriminate against someone because of their faith. So you cannot exclude them from certain groups. You can't exclude them from participation because of the faith if you have to offer some alternative at the provider level that if the individual doesn't want to go to this group, then they can go to one that's not faith-based, but they have to be given that choice. Next slide.
Yeah, Rick, I was going to back up to the point about it prohibits the use of block grant funds for religious activities. We just want to be clear that essentially what the requirements call for is that it doesn't prohibit the organization from engaging in religious activities, but it can't be done at the same time that block grant funded activities are taking place or in the same location. I mean, you can use a room, a chapel, or anything like that, as long as block grant funded activities aren't taking place at that time.
Yeah. The issue around that is that you can't use a block grant funded activity to proselytize any religious faith. So it's there for the treatment services and treatment services alone. Yeah. Okay, let me talk about other, requirements. The stuff that in my last years I've grown dear and fond of in terms of other fiscal audit requirements. The fiscal requirements that apply to the block grant are that non-federal entities who have, get an award of $750,000 or more in federal expenditures during the year. Now that's across all funds, must receive a single state audit. So not just one entity, from one agency, but it's across all of the state funds together. They can elect to have a state single audit, or they can have a program-specific audit, as long as they meet certain conditions as required in 2 CFR 200. Non-federal entities that expend less than $750 are exempt from the federal audit, but most of the times you need to check with your state contracting entity. They have to have an audit opinion that has to be rendered. So it isn't just like they're just scot-free. They have to have an audit opinion in order to comply usually with state regulations, but check with your funding entity.
And Rick, these requirements are generally federal fiscal requirements, so they're not just about the block grant, correct?
That's correct. Yeah, and those come from the regulation that I read, the 2 CFR 200 that was amended and came into play in the last 2 years. Those are all of the audit requirements and the fiscal regulations pertaining to all federal funds. Okay. The things that are important to remember as a part of this, that there are certain restrictions on the block grant that are prohibited. So, for example, providing inpatient hospital services, except under certain conditions, is prohibited. Making cash payments to recipients, so you're giving somebody cash to come in or do something, you can't do that. Purchase or improve any kind of land, purchase or improve buildings, facilities, any major medical equipment, you cannot use the block grant funds for that. Satisfy a requirement expenditure of non-federal funds, for example, using you have to have something as a match for another grant. You can't use block grant because it's federal funds, but it's also prohibited. You can't provide financial assistance to any entity that's other than public or not for profit. For example, some agencies are now coming into play as we get into healthcare that are for-profit companies. Well, they have to use state funds or some other funds, but they cannot use block grant funds. You cannot use it to provide individuals with hypodermic needles or syringes, and you can't expend more than the block grant expended in 91 for any services that if you are as a state or as a company, a local provider providing services in a penal or correctional institution. So that's a marker in 91. You can't spend any more than that. So those are some regulations and restrictions that at the local level, the provider level, that you can't use those funds for. Okay. Next slide.
And for folks' convenience, we basically did a lineup in case any of the organizations also receive mental health block grant funds. You can see
the same,
crosswalk between there are a lot of common prohibited expenditures there.
Yeah.
And I think in 25 years, I only know of one organization that actually knew how much they were spending in 1991 in correctional institutions. So basically, my recommendation to people is tend to use that as like a third rail and stay away from it.
Yeah, just stay away from it. Yeah, that's usually the best idea. Use your state money for that. Okay. You also cannot, one of the other salary limitations are that subrecipients per local community providers cannot use block grants to pay for salaries in excess of the level 1 federal senior executive pay scale. So, you know, you can't use, I think, you know, I think the last was what? The federal senior one, I think it was $270,000.
It was about $207,000 in fiscal year 2017, but I haven't checked since the fiscal year 18 just started.
Yeah, but you cannot. There's a ceiling cap on senior executive pay in the providers that receive block grant monies. That's the point we wanted to make. So
a few other kind of programmatic items to walk through. One of the requirements that the states adhere to is they have to conduct independent peer review of at least 5% of block grant funded treatment entities in the state each year. And so it's not a lot, but it's still a requirement. The reason why we listed it here, even though that's a requirement for the state, they may in turn require you all provider organizations to be involved or to be either as, particularly as recipients of the peer review. And so we wanted to just explain to you how kind of some of these requirements kind of trickle down, and this is certainly one of them. Reviews are not regulatory. They're not a part of a contractual kind of activity. They are really more quality, continuous quality improvement in orientation, and they focus, or what the block grant requires them to focus on is areas of, such as quality of care, appropriateness of care, and efficacy of care. And so those are the three areas. How states do peer review varies quite drastically across the country, but there are some basic requirements that they have to adhere to in terms of who's a part of the peer review process. It shouldn't be, for instance, someone from the program under the organization under review. It really shouldn't be someone who has decision-making authority in terms of the program's, say, state licensing or funding activities. And so it's typically peers, and it should be folks who are, the peer review team might consist of people who are quite familiar with that type of service and preferably represent some of the types of professionals who are represented in the programs under review. So there's no formula for it. It's actually 5% for a larger states really means that you can kind of get around quite a bit before peer review comes your way. In smaller states, it might not be the same. But that's kind of one of the requirements that the state has, and they might ask you all to participate in the peer review process in one way or the other. There are a couple of other requirements that have been long-standing requirements. One has changed a little bit in recent times because of the Cures Act. But the first one is really, there's never been a change in terms of the need to protect patient records from inappropriate disclosure. So that's always been at hand. One of the requirements that's also included in the block grant is that it requires the states and in turn possibly the provider organizations to provide education on the requirements around protecting patient records, including the requirement that certain disciplinary actions will take place for inappropriate disclosures. Obviously, this is a different requirement today than it was, say, 25 years ago. when there were fewer and fewer electronic health records. And so ANSI has been upped in terms of what folks have to do in terms of securing and protecting patient information. So it's not just, the hard copy files that folks used to file back in, the 90s, but it's also the electronic records. Mm-hmm. And communication that takes place between and about clients.
Yeah, and I was going to add, Larry, in terms of, more so at the provider level now, is that this requirement of educating staff on how to adhere to those regulations, and in more commonly, we've seen agencies having to review and analyze the use of email, secure systems for sending information about clients, those kind of things. That all has to be a part of that local level education.
And then the other requirement that actually was kind of under those other category is it used to be in the block grant, there was a requirement to basically ensure that people who provide prevention and treatment services receive access to continuing education and training. The 21st Century Cures Act provided more definition of that requirement, and it now basically, I'm just kind of paraphrasing what the requirement is on the slide here, is to make sure that we offer prevention, treatment, and recovery personnel ongoing training in specific matters that would improve substance use disorder prevention and treatment services in the state. So it's much more defined. They actually give some examples of what that might entail. All right, so I'm going to back up because my good friend Sandy Starr from Ohio has a question. And Rick, Sandy wants us to go back through slides 36 and 37?
36 and 37, yeah.
Okay.
Okay.
All right, so Sandy, keep typing. Tell us if there's anything in particular that you want us to cover while Rick is talking.
Amy.
Okay. Yeah.
Amy Anderson? Okay, I thought that was Sandy. Okay. But Sandy has something too, though.
Stanford Star?
Yeah.
Okay.
So let's go with Amy's question first.
All right, so can you review slides 36 and 37 again? She needs clarity.
Okay. Slide 36 lays out expenditures that are expressly prohibited within statute for the use of any of the substance abuse block grant, but also the mental health block grant funds. For example, prohibited expenditures, going down through them, you are not allowed to provide inpatient hospital services except under certain conditions as outlined in the regulations. You cannot make cash payments to recipients or intended recipients of any of the health services funded by the block grant. You cannot use the funds from the block grant to purchase or improve land. You cannot use it to purchase, construct, or permanently improve buildings or other facilities, also known as capital projects. You cannot use it for purchasing major medical equipment. You cannot use the block grants to satisfy any requirements for the expenditures of non-federal funds, such as a condition of receipt of federal funds, sometimes seen as a match, those kinds of things. You cannot use it for that. You cannot use it to provide financial assistance to any other entity other than a public or non-private or non-public or non-profit, entity. So you can also not provide individuals with hypodermic needles or syringes. You cannot expend more than the amount of the block grant funds expended in federal fiscal year 91 that was expended for services in a penal or correctional institution of the state. So like Larry said, most people can't remember that. I would just say probably just prohibit use of the block grant monies, use state monies for that. Go to slide 37.
So I guess the bottom line of what Amy's asking is that we really just can't, you can't spend the block grant money on those activities unless otherwise, unless you meet some of the exceptions to the rule that are there. So I think one of the examples is if you are considering a capital improvement of a building, so major construction, like you're renovating the building, you can't you can't use the block grant funds for a purpose like that.
Right.
If you, I don't know what would major equipment constitute, Rick?
Major medical equipment?
I'm thinking like construction equipment, but I don't think.
Well, major medical equipment would be things like if you're buying scanning equipment, MRI equipment, or like a toxicology, a medical device that actually takes in samples and, does toxicology tests of that. You can't use it. That's considered to be a major medical equipment.
No can do.
No, not with block grant money. You can use your state money, but you can't use that. And then you also,
that's a simple one.
Mm-hmm.
You can't pay someone a salary above that level. The level of the salary is actually listed in the Office of Personnel Management. You can get the schedule there, and it changes from year to year because the amount changes. I think when the block grant began, that amount was like $125,000 a year. Now it's almost $100,000 more than that. So it just means that you can't pay someone out of the block grant funds a salary that exceeds that amount.
That's right. Yeah, you can't use block grant funds for that. That's right.
Okay. All right.
Did that answer Amy's question?
We think so.
Okay.
All right. So let me just present the schedule for the rest. So this was really just intended to be kind of Rick, what do you call this? A 20,000-foot level?
Yes. Yeah, I called it the 20,000-foot level perception of the block grant.
Yeah, and so we wanted to just give people kind of the breadth of the requirements. In these sessions, an hour doesn't give us the depth, but we will go deeper in on some of the other subjects in the other three sessions, but we're going to be very specialized and focused. So again, on November 16th, we are covering the requirements regarding special services for pregnant women and women with dependent children. On December 7th, we'll be covering the capacity management requirements in more detail. And on December 14th, Rick will be covering the block grant fiscal requirements around tracking and management of block grant funds in more detail. All right, and so I guess I turn to Laura. You have questions?
Yeah, we have a couple of questions. The first one is single audit requirements. Who are considered non-federal entities and who are not?
Well, non-federal entities are folks that, that are not, they're not seen in the slide. If you pull that slide up, the issue is whether or not you get federal funds and how much you get from the federal funds. Oops, let's get back. Yep, right there. Okay. In federal, it isn't so much federal entities, but non-federal entities are the ones that expend less than $750,000 in federal funds. So it's non-federal entities are ones that are not, they're not like a federal government entity. Okay, so if...
So I guess we're talking about like the state agency,
right.
A county, a regional entity, nonprofit, provider organization.
Yeah, they're seen as provider organizations, I guess is the best, I was trying to think of the best word, but they're provider agencies that are not designated as federal, so it's not a federal arm of the government. These are other people that are either subrecipients or pass-through agencies that are seen as either local providers or local entities, and that they're spending money that is given to them from a, like CSAT or some other federal entities. So.
Yeah, and the way, the trickle down of the cash in terms of the block grant from, the federal government, as we said in the earlier slides, allocates the funds to the states. They are the block. They are the recipients of the block grant. They are the signatories of the block grant application. They then, through whatever means is specific to that state, then will allocate funds. And some of you are probably in states that have what we refer to as intermediaries. And so those intermediaries will be recipients of the block grant fund. And they will either in turn deliver and or contract for services at the provider level. In some of your states, you have a direct relationship with the state agency, and so they contract with you directly. And so essentially any of those, what we refer to as subrecipients or recipients of the block grant fund.
Right.
And if you get that amount, you're basically required to have that particular type of audit.
Right.
All right. Other questions?
Peer review requirements. Agencies with national accreditation are exempt?
No.
No.
That was a fast one. Because peer review is really not about CARF or JCO accreditation or say, state regulatory requirements. It is whatever the state decides in terms of quality, efficacy, and appropriateness. And the state systems come up, but they are pretty much independent peer review systems, and so they're different from CARF and JCO in that regard.
Right. Yeah. It's a quality control measure embedded within the regulations, so it applies to anybody who receives those block grant funds.
Okay. Next question, how much has the total block grant amount increased since 1993?
I don't remember. It has, that much I know, but I don't remember how much it was back then. It was, it's about $1.8 billion now.
Oh, yeah, I don't know what it was in '93.
Yeah. I don't know, and Gail, if anyone, I know, because there are only probably a few of us who were around and doing work on it around that time. I don't know if Gail, if Saunders, if you or anyone else at SAMHSA knows. John Campbell would probably know, but unfortunately John had a conflict with this time.
Okay. The other question is, does SAMHSA have a training on protecting patient records and or education on how to adhere to these regulations?
So on the latter part, I can answer that. We do, if you're talking about the block grant regulations, and I'll be careful about the answer, we do have more extensive training for states on the block grant regulations. I'm not so sure about, and I think that's probably a question that I would punt to SAMHSA about whether or not there's any training currently on training around client confidentiality, protecting patient records.
So John Campbell is actually on, and he said to give him a second, he could actually provide the fiscal year 1993 SABG amount.
I'm actually surprised John doesn't know that off the top of his head. He usually does.
Oh. Thank you, John.
And Gail respond, they should work with the SPO and also check the SAMHSA website in regards to the question.
The question about confidentiality? Yeah. Yeah.
Okay, the next question is the 5% IPR. Is it correct that national accreditation agencies do not require peer review?
Well, I don't think we can speak for the national accreditation. We're only referring to the block grant. So I have actually not as up to speed on CARF and JCO and those accreditation bodies. Rick, do you know?
No, I don't.
I don't recall historically they had a peer review requirement. Someone else on the phone might know.
But again, simply, I mean, because they have that accreditation doesn't exempt them from, in the system, the state, from assuring that the peer review is conducted in accordance with the block grant requirements.
Since the opioid public health emergency, can we now expend block grant funds to distribute hypodermic needles or syringes? harm reduction?
To my knowledge, I don't think that's been reversed, but I think that's another one we'll probably, if John is on, we'll defer to SAMHSA.
Yeah, defer to the SPOs.
Okay. Can you speak to the exceptions for use for inpatient hospital services?
Rick, you know them by heart?
Well, I don't know by heart. I do know that it has to be deemed as medically necessary, and it has to be shown that it's not above the average cost for an inpatient residential day in the system as it is, and it has to be pre-approved by the SPO as an exception to the rule. I know those three things.
One second. Okay. Would you be able to explain more about cash payments?
Cash payments in terms of how the block grant is dispersed?
Yeah, I think they're probably talking about cash payments to recipients.
Oh, to recipients, yes, okay. Cash payments to recipients is, refers to if you're paying someone to participate in a group session, giving somebody $10, $5, or to complete a survey, or you're giving money to people who are giving services for a specific, activity that you want them to complete. So you cannot use the block grant monies to do that. You can't pay someone to, come to group, or pay someone to follow through with, taking their meds or those kind of things. You're not allowed to use the block grant for those kinds of payments. And sometimes they, some programs, for outreach programs especially, will, give out cash for incentives for, participating. Come to the group, and we'll give you $5 to go buy pizza or something like that. Like, no, you can't do that.
If you don't have contracts with faith-based organizations, what is needed for charitable choice?
Well, you have to just assure, you have to have a charitable choice policy that says that individuals are not being discriminated against on the basis of their faith. And so you just have to, if you're not a faith-based entity, you have to still have that policy in there. As an example, we had some agencies that they had a complaint about someone coming to an AA group, because what does it do? It says you put your faith in a higher power. Well, they felt they were agnostic, and they were did not want to come to that group. So then the agency has to offer some alternative self-help group that is equal to that one, so that the person is not discriminated against on the basis of their faith. So that's the the non-faith-based ones. That's what they have to just have that in place, and they have to practice that policy and show how they're adhering to that policy. But they do need to have a policy in place, policy and procedures.
So peer review follow-up question. So accredited agencies are not exempt from these, but we, if we have enough of them, accredited providers, parentheses, more than 5% of all providers, states are exempt from conducting the peer review for that year, correct?
Say that again.
Okay.
So I think, are they basically asking that if they have more than 5% accredited organizations, I don't think that bears on whether or not peer review is required or not. It's a matter of the 5% basically means that if you have 100 providers in a state,
right,
you need to conduct peer review activities on 5 of them.
Yeah, you have to do the 5%, and then each year you need to also assure that you do 5% of the entire, the selection pool. So it's 5% of all those companies that are receiving block grant monies.
All right. So a couple more questions, I think, because I think we're at time.
Okay. Someone would just like a clearer answer on the syringe question.
On the
we are going to defer that question to SAMHSA. I've not seen anything that reverses it. But
no, I haven't either seen any block grant directives or letters that said that you could use block grant monies for that. Now, if that was in their, in their STR award, that's a different issue, but not in the block grant. I haven't seen anything.
Okay. Where would we find the information regarding exceptions in the presentation, but you don't give the specific details?
Okay. So one of the things that we'll do is we'll provide folks the, so they're talking about the exceptions probably for inpatient. We can provide more detail in writing on that. It's basically, we'll pull it directly from the block grant requirements. It's a fairly complex list of items.
Okay. And we have a comment from Teresa Mitchell-Hampton.
Oh, great.
She said, written policy and procedures show you have advertised availability. And then John Campbell got back to us with the fiscal year 1993 SABG allocation. And
how much was it?
$1,108,298,217.
Oh, John, I was going to guess somewhere around 1.2. Okay. And I'm going to go back to Teresa's comment, too, because I don't think I mentioned this when we talked about the women's services, but Pam will talk about it next week. That is that states and providers also have to advertise the fact that women get, pregnant women are given priority in admissions.
Gail also sent us a comment, and she said, correct, 5% each year of entire program. So that was back to the 5% question.
Yeah.
Okay, and then we got another question. What I'm asking is how we can hear from SAMHSA about this.
Can you trace back to what the original?
There are some recent statements coming out about this over the past week in different area of SAMHSA funding.
Do we know what this is?
What about?
Let's see. Okay, we're back to the possibly the clear answer regarding the syringe question. So it's in regards to that.
All right. So I don't know if anyone from SAMHSA wants to chime in now, if possible, but if not, we'll send out a we'll ask them about the response.
Yeah, yeah. We can send it out. I have it on my hard drive.
Okay.
Are there other questions?
All right. We have a comment from John Campbell.
Okay.
So please note, SABG funds fiscal year 2016, fiscal year 2017 can be expended to support elements of a syringe service program, subject to the syringe services program guidance published on the SABG website. To date, no state has submitted an amendment to their respective biennial plans to repurpose SABG funds to support elements of a syringe services program. So that's the comment on that.
So last year it was allowed, but no one has actually taken them up on that. Okay. Hot off the presses.
Okay.
All right. Anything else?
I think there was one more question. Let me just double check. Okay. So as the SSA, I really don't think their answer to my last question was correct. There is an exemption around the peer review requirement based on the percentage of providers who have national accreditation. I have used this exemption in the past just wanted to confirm that my understanding of it was correct.
Okay, so that's probably another one of those we'll defer to SAMHSA as well, because if there's more recent, something that's different from what's in the original block grant, we'll probably defer that one.
Okay, and that's it.
Yeah, and we'll be sure. I think for the questions that we haven't responded to, we need to note those, and we'll send out. We'll confer with SAMHSA and send out responses.
Okay. And that's all I have.
All right. So thanks, everyone. Just remember the sessions that are coming up.
Okay.
On the 16th and the 7th and 14th of December.
And we'll be sending out invites for that through email.
Okay, great.
All right. Thank you.
All right, you all take care.
Okay. Thank you all.